Hey guys, welcome back to Circulatory System. So this is Dr. Piri taking you in human physiology. So today we'll be discussing venous return and cardiac output. So what you need to know is the heart is able to pump blood out of what is returning to the heart. That's why it's very important for us to discuss the venous return before we discuss the cardiac output. So this is Circulatory System, Lecture 5. So in this lecture, what are we going to discuss? Of course, by now you have an idea. We're going to look at the venous return, then the cardiac output, the factors affecting cardiac output, and also, if we'll have time, we'll also discuss measurements of cardiac output. If we won't have much time, then I'll give you a reading assignment to go and read on how you can measure the cardiac output. So why do you want to measure this cardiac output? Is because it's very important for you to know how the heart is functioning. So the normal function of the heart, you need to look at the efficiency of the heart. So sometimes if you have a reduction in cardiac output, it means that the efficiency of the heart is reducing. So to some extent, you are able to know the functioning of the heart by looking at the cardiac output and also the venous return. So under normal circumstances, you find that when you look at the values of the venous return and cardiac output, they should be the same. Because remember, the blood that is returning to the heart is called the venous return. Then the heart that is pumped out of the heart, this is cardiac output. So the heart is only pumping what is returning into the heart. So under normal circumstances, you'll find that when you have the average values of the venous return should be the same as the cardiac output. But in as much as these are interdependent factors, the mechanism that are involved in regulation of cardiac output and venous return, these are two different mechanisms. So in as much as they are interdependent factors, you find that the regulation of venous return and cardiac output might be different. That's why we need to discuss the venous return and cardiac output. So the previous lecture, we are looking at the cardiac cycle. So you know how the heart is able to contract, to eject blood into the aorta. So I hope you remember all the 7 phases of cardiac cycle. And during the period of ejection, you know to say that there is stroke volume that is ejected into the aorta in the pulmonary trunk. So this is what we are discussing here now. So for you to have that ejection, first you need to have venous return. So now let's start. So we'll start by discussing venous return according to the outline that I've given you. So it means that the objectives of this class, at the end of this class, you should be able to define venous return. You should be able to describe factors that are affecting the venous return. Then you should also be able to describe cardiac output and all the factors that are affecting cardiac output. Then you should also be able to describe methods in which you can measure the cardiac output. So let's start by discussing the venous return without wasting much time. So like I said, this is just the blood that is returning to the heart. So it's very easy to define it. So the venous return is the flow of blood back to the heart. So the flow of blood back to the heart, that's the venous return. So under steady state conditions, the venous return must equal cardiac output when averaged over time, because the cardiovascular system is essentially a closed loop. Otherwise, blood would accumulate in either the systemic or the pulmonary circulations. So what this means is that because the circulatory system is a closed loop, it means that the venous return should be almost equal the cardiac output. Otherwise, if they are not equal, you find that there could be accumulation of blood maybe in the pulmonary circulation or systemic circulation. But as long as the venous return is almost equal to the cardiac output, you find that this is just a system in which blood will be just circulating across the body. So although the cardiac output and the venous return are interdependent factors, each can be independently regulated. So you find that the regulatory mechanism could be different for the venous return as opposed to the cardiac output, in as much as you want these factors to be almost equal in terms of their values. Okay, so let's look at factors affecting venous return mechanisms. So there are about 6 factors that are affecting the venous return. So these are just major factors. There are also other minor factors that we won't discuss them here. So I just want you to understand these 6 factors that are affecting the venous return, starting with the musculovenous pump. So we're going to start with the musculovenous pump. Sometimes it's also referred to as muscle pump. So what do I mean? So you know that muscle cells that are involved in contraction and relaxation. So sometimes if you have a vein in between the muscle fibers, as these muscle fibers or muscles are contracting, they can massage or squeeze the vein. So as the vein are squeezed or massaged by the muscles during contraction, that will help to push blood towards the heart. Because remember, the veins, they have valves. So the only way the blood can move is upwards towards the heart once there is a contraction, hence squeezing the veins in between these muscles that are contracting. So this mechanism is called musculovenous pump. The muscles that are contracting to squeeze the veins. So musculovenous pump. So like I said, there is rhythmical contraction of limb muscles as occurs during normal locomotory activity. For instance, walking, running, swimming, that is going to promote the venous return by the muscle pump mechanism. So the diagram down here, you can see you have a leg with the calf muscles, and associated with the calf muscles, we have a lot of veins here. So when these calf muscles are contracting, so if there is a vein in between the muscles, as these muscles are contracting, they're going to massage or compress the veins. And as the veins are being compressed, you'll find that the blood will start moving because they are squeezed. So as this blood is squeezed, you have the valves that are going to prevent the backflow of blood. So the only way is this blood to move towards the heart. And this is going to increase the venous return. That's why it's always important to do a bit of activity with the muscles so that you are going to improve the venous return. So if the venous return is improved, even the cardiac output is also going to improve. Then you are also facilitating the function of the heart. So this is one factor that will have an effect on the venous return. It's called musculovenous pump or muscle pump. Then the other factor is decreased venous capacitance. You know to say that the venous system is also referred to as capacitance system. It means that blood can accumulate within the venous system. So if you have decreased venous capacitance, it simply means that you are reducing the diameter of the veins. For instance, if you have sympathetic stimulation, that will result into vasoconstriction. So the veins will start reducing in terms of diameter. That will squeeze the blood. Now the blood will return back to the heart. So when you have decreased venous capacitance, that will also result into an increase in venous return. So decreased venous capacitance. So like I said, the sympathetic activation of the veins decreased venous compliancy. So when you're talking of compliancy of the veins, it means as blood is accumulating within the veins, you find that the veins are supposed to enlarge, to accommodate more blood. So that is referred to as compliancy of the veins. But when you have sympathetic stimulation, you know to say there's release of norepinephrine, and that norepinephrine will result into contraction of smooth muscles. So as smooth muscles or the veins are contracting, the diameter is reducing. That will result into a decrease in the capacitance and also the compliancy of the veins. Hence now squeezing this blood, and the only way is this blood to return back to the heart. So the venous return is going to increase as a result of sympathetic activation of the veins. So once you have this sympathetic activation, it's going to cause an increase in vasomotor tone because of the norepinephrine that is stimulating the smooth muscle cells. So you're going to have vasomotor tone that is going to increase. Then you're also going to have an increase in the central venous pressure. So the central venous pressure is going to increase. Why? It's because the peripheral veins, they are having more of vasomotor tone. So they are contracting, the smooth muscles are contracting. That will result into more blood moving towards the central vein. You're talking of the inferior and the superior vena cava. So you have more blood that is returning to the heart via the inferior and superior vena cava. That is going to result into an increase in the central venous pressure. And that is also going to promote venous return indirectly by augmenting the cardiac output through the Frank stirring mechanism. So the Frank stirring mechanism, we are also going to discuss it when we start looking at the stroke volume or the factors that can affect the cardiac output. So this Frank stirring mechanism simply means that when the cardiac muscle cells are stretched, if you remember very well when we were discussing skeletal muscle cells, we say that we looked at the length tension relationship of skeletal muscle cells, whereby when you stretch the skeletal muscle cells, you are exposing more actin to myosin. That will increase the contractility. So the tension within the muscles is going to increase. So that is also taking place within the myocardium or the muscle cells of the heart. So once you have venous return, so if the venous return is increasing, it means that you are stretching the myocardium more. As you are stretching the myocardium, you are exposing more of myosin to actin. So the more they are exposed, the contractility of the myocardium is going to increase. Once the contractility of the myocardium is increasing, it means that also the stroke volume is going to increase. That will result into an increase in cardiac output. So we are going to discuss that. But just not to say that once you have sympathetic activation, you have an increase in vasomotor tone that will result into an increase in central venous pressure, and this will result into an increase in venous return. And this venous return will result into Frank stirring mechanism. If you don't understand this mechanism, I'll still explain in this lecture later on. So which increases the total blood flow through the circulatory system, because when you have an increase in venous return, the contractility of the muscles are going to increase because of Frank stirring mechanism. The cardiac output is going to increase, and then you're also going to increase the blood flow across the circulatory system. So this factor will have an effect on venous return, decreased venous capacitance. So it means that the venous return is increasing because much of the blood is returning to the heart. So you can see in this diagram here, you have the heart, you have the arterial system, the venous system, then the capillaries at the center. So the arterial system are regarded as distribution blood vessels. So they are going to distribute the blood that is coming from the heart. Then you have the small arteries and the arterioles. So the small arteries and the arterioles, these they are high in terms of resistance. So these are resisting blood vessels. So they are going to resist. That will result into an increase in afterload that I'm also going to explain later on. And between the venous and the arterial system, of course, you have the capillaries where you have exchange coming from the arterial side, going towards the venous side. Then the venous side, these are considered as capacitance blood vessels. So capacitance because they have the capacity to store large volumes of blood. But once you have sympathetic stimulation, that will result into vasoconstriction, and that will also result into more blood returning to the heart. So the venous return is going to increase as a result of decreased venous capacitance. Then the third factor is respiratory pump. So the respiratory pump will have an effect on venous return. Why? It's because during inspiration, the intrathoracic pressure is negative. That will provide suction of air into the lungs. So inflation of the lungs is due to a decrease in the intrathoracic pressure. So it's going to become negative during inspiration. Then the abdominal pressure is positive during inspiration. So we said the intrathoracic pressure is negative, but the abdominal pressure is positive. So it has got the compression of abdominal organs by the diaphragm. Remember, during inspiration, the diaphragm is contracting. So it's squeezing the abdominal organs. That is, it's going to result into an increase in abdominal pressure. So one thing that you need to know is that during inspiration, the intrathoracic pressure is negative, then the abdominal pressure is positive. So this makes a pressure gradient between the infra and the supradiaphragmatic part of the inferior vena cava, pulling the blood towards the right atrium and increasing the venous return. What it means is that, maybe this doesn't make sense, by looking at this diagram, maybe you'll be able to get the point there. So this is during inhalation or during inspiration. So during inhalation or inspiration, it increases blood flow into the thoracic vein. Why? It's because there is decreased intrathoracic pressure. So because when the lungs are inflated, you find that there is decreased intrathoracic pressure. That will result into the veins becoming open for movement of blood across it. So the diameter is going to increase because you have decreased intrathoracic pressure. But when you're looking at down here, after the diaphragm, you have the abdomen. So the diaphragm is going to contract during inspiration, and that is going to result into an increase in the abdominal pressure. So because there is an increase in the abdominal pressure, that is going to compress the veins. So you can see the compression of the veins here because of increased abdominal pressure. That will result into squeezing of this blood towards the heart. But within the thoracic cavity, the veins are open, so blood can easily move back to the heart. So inspiration has got an effect on venous return. So this is referred to as respiratory pump, which is opposite during exhalation or expiration. So in exhalation, there is an increase in blood flow into the heart and abdominal veins. Why? It's because there is an increased intrathoracic pressure that is squeezing the superior vena cava. So if the superior vena cava is being squeezed, it means that blood is also moving to the heart. So you're going to have an increase in blood flow into the heart, again, during exhalation or during expiration or exhalation. Then when you're looking at the abdominal cavity, in the abdominal cavity during exhalation, you have a decrease in intra-abdominal pressure. So because you have a decrease in the intra-abdominal pressure, it means that this inferior vena cava is going to remain open. Then that is going to provide the capacitance that I'm talking about. It's going to store blood. But this will have an effect on the venous return because blood is not moving back to the heart from the inferior vena cava, then the venous return somehow is going to reduce as a result of exhalation. So this mechanism is referred to as respiratory pump, which has got an effect on the venous return. Then the other factor is vena cava compression. So vena cava compression takes place during two processes. You have pregnancy and another mechanism that I'm going to explain. So here it is. So the vena cava compression, an increase in the resistance of the vena cava because the vena cava now is being compressed. So this is mainly the inferior vena cava that is being compressed. Then there's an increase in terms of resistance. So there is no normal flow of blood when the vena cava is compressed. So there is minimal amount of blood that is passing through the vena cava because the resistance has increased as a result of compression of the vena cava. So this compression is prolonged to the extent that, yes, during initial stage of compressing the vena cava, there will be an increase in venous return. But if this compression is prolonged, you find that this blood is very difficult for it to return back to the heart after that, because now the resistance of the vena cava has increased. So an increase in the resistance of the vena cava as a result of thoracic vena cava that becomes compressed during Valsalva maneuver or during late pregnancy. So in late pregnancy, there is compression of the vena cava because of the baby that is developing within the fetus. So that's why pregnant women, they are advised not to sleep in a supine position. Why? It's because that will bring about compression of the vena cava. Then the Valsalva maneuver is whereby when you close your nostrils, and then you're breathing against the closed glottis, that will result into compression of the vena cava. So from the diagrams, you'll be able to understand. So this is Valsalva maneuver, whereby you close your nose and then you're breathing against the closed glottis. There will be an increase in the intra-abdominal pressure that will result into compression of the inferior vena cava. And to some extent, there's also compression of the superior vena cava. That will result into the reduction of venous return. So the venous return is going to reduce because of vena cava compression. Then during pregnancy, late stage of pregnancy, you can have vena cava syndrome, whereby if the pregnant woman is sleeping in supine position, the baby weight will be compressing the vena cava. That will result into vena cava syndrome. So the venous return is going to reduce. Okay, that's why in late stage of pregnancy, a pregnant woman is advised to sleep on right lateral position. So you can see here the right lateral position, which is normal. Otherwise, if they are sleeping in supine position, there will be vena cava compression that will reduce the venous return. And that can bring about other issues because there'll be less blood that will be going to the circulation as a result of an increase in the resistance of the vena cava. Then the other factor is gravity. So of course, gravity will have an effect on venous return, whether you are standing or you are sleeping. Okay, so gravity effect on the venous return. So the effects of gravity on venous return seem paradoxical, meaning that it seems to be contradicting itself. Why? It's because when a person stands up, the hydrostatic forces cause the right atrial pressure to decrease and the venous pressure in the dependent limbs to increase. So here, you're having a decrease in the atrial pressure, but you're having an increase in the dependent limbs veins. So the veins in the extremities, the hydrostatic pressure is going to increase. But within the atrial, the pressure is going to decrease. Why? It's because when you're moving from lying position to standing upright, you know to say that the gravitational force will force the venous return to go back into the extremities. So blood will be accumulating within the extremities. That's why you're going to have an increase in the venous pressure in the dependent limbs, but you're going to have a decrease in the atrial pressure because to some extent the venous return is going to reduce. So even the atrial pressure is also going to reduce. So this increases the pressure gradient for the venous return from the dependent limbs to the right atrium. However, the venous return actually decreases. So you know to say that in as much as you are having an increase in the venous pressure within the dependent limbs, but overall you're going to have a decrease in the venous return because the right atrium pressure is going to reduce as a result of gravity. So the reason for this is when a person initially stands, cardiac output and arterial pressure decreases because the right atrial pressure falls. So the cardiac output and the arterial blood pressure is going to decrease. Why? It's because the right arterial pressure is going to fall as a result of gravity. So if the arterial pressure is reducing, it means that the ventricular filling is also reducing. That's why the cardiac output is also going to reduce and the arterial pressure is also going to reduce. So from this diagram, you can also see that when you are lying in supine position, so blood is mainly located within the central veins. So you can see that the central venous volume is increased, then the central venous pressure is going to increase. That is going to increase the venous return. And when you're increasing the venous return, the cardiac output is also going to increase, and the mean arterial pressure is going to increase as well in a supine position. So gravity has got no effect when somebody is lying straight. So when you're lying down straight in supine position or lateral position, ventral position, whatever position, when you're lying down, the gravitational force has got less effect on the venous return, or it's going to increase. The venous return is going to increase because that gravitational effect is not there. But when you change now from supine position to standing up, as you are standing up, the gravitational force will have an effect on cardiac output. So you can see here now, when standing, you can see that blood is accumulated within the extremities. So there is an increase in blood volume in the extremities. So these are the dependent limbs or the extremities. You're talking about the legs and the hands. There will be an increase in venous pressure within these extremities, but there will be a decrease in the central venous volume because this blood has moved to the extremities. There is also a decrease in the central venous pressure. So if the venous volume is decreasing, the central venous volume is decreasing, and the central venous pressure is also decreasing, it means that the venous return is going to reduce, then the cardiac output is going to reduce, and there will be reduction or a decrease in mean arterial pressure. So you can see the effect of gravity on venous return. So as you stand up, the venous return is going to reduce as a result of gravitational force. But when you're lying in supine position, lateral position, ventral position, the gravity has got less effect on the venous return. Then the last factor is the pumping action of the heart. So the pumping action of the heart has got an effect on the venous return. So what do I mean? So this pumping action of the heart, during the cardiac cycle, the right atrial pressure changes outer the central venous pressure. So you know to say that there are no valves between the atria and the large veins. So there is no valves between the atria and the inferior or the superior vena cava. So there are no valves there. So whatever pressures are taking place within the atria, they will be transferred to those larger veins. That's why I'm saying that the pumping action of the heart has got an effect on the venous return. So for instance, during atrial systole, it means that the atria are contracting to add that 20% to the ventricles. Remember, we said in the cardiac cycle, the 80% of blood is passively moving from the larger veins into the atria and then into the ventricles. And then the 20% is as a result of the contraction of the atria. So as the atria is contracting, blood is being squeezed into the ventricles, but some of the blood is also pushed into the larger veins. So the superior and inferior vena cava. So when the atria are contracting, some of the blood is backflowing to the atria, to the superior and inferior vena cava. So it means it's also going to interfere with the venous return because it's against the pressure that is bringing blood to the heart when the atria are contracting. So the pumping action of the heart, they've got an effect on the venous return. So because there is no valve between the heart's atria and large veins, the central venous pressure reflects right atrial pressure. So it's going to reflect the right atrial pressure. Therefore, the right atrial pressure also alters the venous return. So the activities of the atria can also affect the venous return, depending on the pressure within the atria. Okay, so we proceed. So let's look at the cardiac output. So now we are done with the venous return and factors that are affecting the venous return. So now let's discuss the cardiac output and also the factors that can affect the cardiac output. So you need to be able to define the cardiac output. So the cardiac output is defined as the volume of blood ejected from the heart per unit time. So it's simply the volume of blood ejected from the heart per unit time. Mainly is measured per minute. So the amount of blood that is ejected out of the heart per minute, that is referred to as cardiac output. So the usual resting values for adult are about between 5 to 6 liters per minute, approximately 8% of body weight. So it means, since we said total blood is about 8% of the body weight, and then here we're saying the cardiac output is about 8% of body weight. So it means that in every minute, the entire blood that is found within the body goes into circulation across the heart, because the heart is pumping this blood 8% of body weight in every minute. So it means that every minute that passes, the entire blood goes to circulation via the heart. So the cardiac output, so when you do the cardiac output divided by the body surface area, is called the cardiac index. So the cardiac output divided by the body surface area is called the cardiac index. So experiments have shown that the cardiac output increases approximately in proportion to the surface area of the body. Therefore, cardiac output is frequently stated in terms of cardiac index, which is the cardiac output per square meter of body surface area. The normal human being weighing about 70 kilograms has a body surface area of about 1.7 square meters, which means that the normal average cardiac index for adult is about 3 liters per minute per meter squared of body surface area. Why? On average, the cardiac output is 5 liters. So if you say 5 liters divided by 1.7, it will give you something like 2.94. So roughly that's like 3. So it will give you 3 liters per minute per meter squared, because you are dividing the cardiac output, which is measured in liters per minute, divided by the body surface, which is measured in meters squared. So your units will be 3 liters per minute per meter squared of body surface area. So just not to say that sometimes the cardiac output is expressed in terms of cardiac index. And this cardiac index, you are simply dividing the body, the cardiac output divided by the body surface area. So when you divide the two, it's going to give you the cardiac index. So on average, a 70 kg man will give you the cardiac index of about 3 liters per minute per meter squared. So the cardiac output is the product of heart rate and stroke volume. So this is the formula that you need to remember always. It's very easy to remember. So the cardiac output is calculated as the product of heart rate times the stroke volume. So when you multiply the heart rate and the stroke volume, it's going to give you the cardiac output. So the stroke volume is the volume of blood ejected with each beat. So we say the cardiac output is the volume of blood ejected from the heart per unit time, and this unit time is per minute in most cases. But when you're just looking at the volume of blood that is ejected out of the heart in each heartbeat, then you're looking at the stroke volume. So the stroke volume is measured in milliliters per beat. So how much blood is ejected into the aorta in every beat? That's your stroke volume. When you multiply that stroke volume times the heart rate, the number of beats per minute, it will give you the cardiac output. That's what I'm saying. Cardiac output is simply the product of heart rate and the stroke volume. So the factors that are affecting the heart rate and the stroke volume, they'll have an effect on cardiac output. So you can see here that we say that the cardiac output is a product of the heart rate and the stroke volume. The heart rate is measured in beats per minute, the stroke volume in milliliters per beat. The cardiac output is measured in milliliters per minute, sometimes in liters per minute. So since the cardiac output is a product of the heart rate and the stroke volume, any factor that has got an effect on the heart rate or the stroke volume will have an effect on the cardiac output. So we'll discuss these factors. For instance, here you can see that nerves, these are autonomic nervous system that will have an effect on heart rate, of course. We discussed that. Then the hormones, you have those hormones, the catecholamines that have got an effect on the heart rate. So they will have an effect on cardiac output as well. Then on the other side, the stroke volume is affected by the blood volume, because the blood volume will have an effect on venous return. The venous return will have an effect on the stroke volume. Then also vesicular resistance. So the resistance of the blood vessels. So you find that it will have an effect on the stroke volume, because the resistance of the blood vessels will have an effect on end diastolic volume that I will explain later on. So let's go step by step. So since you know the factors that are affecting the heart rate, and we've also discussed the heart rate in the previous lectures, so let's concentrate on the stroke volume. So let's look at the stroke volume. So what is the stroke volume? So we've already defined to say the stroke volume is the volume of blood pumped from one ventricle of the heart with each beat. The unit of stroke volume is measured in milliliters per beat. Like I've already said, the stroke volume is calculated using measurements of the ventricle volumes from an echocardiogram. So an echocardiogram is simply the ultrasound of the heart. So just like you can have ultrasound of the uterus, for instance, if you want to be sure whether somebody is pregnant or not, you can do an ultrasound. So that ultrasound machine has got different transducers. So there's a transducer for the heart, there's a transducer for the uterus. So when you're using the transducer for the heart, then what you're carrying out is echocardiogram. So it's simply ultrasound of the heart, the echocardiogram. So from the echocardiogram, you are able to calculate the stroke volume. So this stroke volume is calculated using measurements of the ventricle volumes from the echocardiogram and subtracting the volume of the blood in the ventricle at the end of the beat, which is called the end systolic volume, from the volume of the blood just prior to the beat, which is called the end diastolic volume. So the difference between the end diastolic volume and the end systolic volume is called the stroke volume. So this is the formula. So the stroke volume is the difference between the end diastolic volume minus the end systolic volume. The end diastolic volume is the volume in the ventricles after relaxation of the ventricles, after filling of the ventricles. So the final volume in the ventricles after relaxation is called the end diastolic volume. Then the volume in the ventricles after contraction is called end systolic volume. So the difference between the two is what is being pumped out of the heart. So that is called stroke volume. Every beat will have given you a stroke volume. So per beat, you have this stroke volume, which is just the difference between the end diastolic volume and the end systolic volume. So we proceed. So the term stroke volume can apply to each of the two ventricles of the heart. So remember, you have the left ventricle and the right ventricle. So each ventricle will give you a stroke volume. So although it's usually refers to the left ventricle, so when you're talking about the stroke volume, mainly you're interested with the left ventricle because this is what goes into the systemic circulation. So the left ventricle contracts with a greater force. So when you're talking of the stroke volume, in echocardiogram, mainly you're looking at the left ventricle and not the right ventricle. So the stroke volumes for each ventricle are generally equal, both being approximately 70 milliliter in a healthy 70 kg man. So on average, a normal person should have a stroke volume of 70 milliliters or 70 mils. So the stroke volume is an important determinant of cardiac output because we said cardiac output is a product of stroke volume and heart rate. So it's an important determinant of cardiac output. So the major determinant of cardiac output is the stroke volume and the heart rate. And also all the other factors that can affect the heart rate and the stroke volume. So when the heart contracts strongly, the end systolic volume can be decreased to as little as 10 to 20 milliliters. So when the contractility of the heart is increasing, it means that you are pumping much of this blood into the systemic circulation and also the pulmonary circulation. So you find that there will be reduction in the end systolic volume because the contractility has increased. Conversely, when large amounts of blood flow into the ventricles during diastole, the ventricular end diastolic volumes can become as great as 150 to 180 milliliters in the healthy heart. So it means that if the venous return is increasing, you find that the end diastolic volume can increase to about 150 to 180. So these are two things. So we said the end systolic volume, when the contractility is increasing or is stronger, you find that the end systolic volume is going to reduce to about 10 to 20. The normal systolic volume is between 50 to 70. That's just a normal systolic volume. But when the contractility is increasing, you find that it will reduce to about 10 to 20 milliliters. On the other hand, if the venous return is increasing, you find that the end diastolic volume is going to increase to about 150 to about 180. The normal end diastolic volume should be about around 120 mils or 120 milliliters. But if the venous return is increasing, then you find that it can increase to about 150 to 180 milliliters in a healthy heart. So by both increasing the end diastolic volume and decreasing the end systolic volume, the stroke volume output can be increased to more than double the normal. So sometimes the stroke volume can be increased depending on the activities of the heart. If the venous return is increasing, the stroke volume will increase. If the contractility is increasing, then the end systolic volume is going to reduce and then the stroke volume is going to increase. So by regulating the two factors, the two volumes, the end systolic volume and the end diastolic volume, it will have an effect on the stroke volume. So on average, men on average have higher stroke volumes than women due to the larger size of their hearts. So basically, men, they have larger hearts. That's why in most cases we say ladies or women, they have a small heart. Even when it comes to understanding, they have a small heart. You don't understand. But that simply means that men, they have larger hearts. Why? It's because you know to say that men, they have more blood as compared to women. So if men have got more blood, you need a bigger heart to pump that more blood to the extremities or to systemic circulation. So on average, men, they have a larger heart than ladies. That's the reason why you find that a man can persevere with certain exercises, but ladies, they will get tired so easily because their hearts are small as compared to men. So this equation here is for the cardiac output. You can see that it's the heart rate multiplied by the stroke volume. Then the stroke volume is equal to the end diastolic volume minus end diastolic volume minus end systolic volume. That will give you the stroke volume. Then there are these factors that are affecting the stroke volume. Then the heart rate. There are also other factors that are affecting the heart rate. So before we discuss these factors that are affecting the heart rate and the stroke volume, then they'll have an effect on the cardiac output. First, let's discuss the ejection fraction. So that's another value that you need to understand when you're looking at the efficiency of the heart or the function of the heart. So the ejection fraction. So an ejection fraction is volumetric fraction of the fluid blood ejected from the heart chamber with each contraction or heartbeat. So the ejection fraction simply means the volumetric fraction of fluid blood ejected from the heart chamber into it with each contraction or a heartbeat. So in every heartbeat, there is some amount of blood that is ejected into the aorta. There's some amount of blood that is ejected into the pulmonary trunk. So that fraction of the end diastolic volume that is being ejected into the aorta or the pulmonary trunk is referred to as the ejection fraction. So although if unspecified, it usually refers to the left ventricle of the heart. So when you're talking of ejection fraction, if it's not specified, then even here, mainly we look at the left ventricle. So you're looking at the amount of blood that is being ejected into the aorta because you're talking of the left ventricle. So this ejection fraction is widely used as a measure of pumping efficiency of the heart and is used to classify heart failure types. So it is also used as an indicator of the severity of the heart failure. So looking at the efficiency of the heart, whether the heart is working very well or poor, you can look at the ejection fraction. So this ejection fraction, if it's increasing or decreasing, you'll be able to tell. So if the ejection fraction is increasing above the normal range, you know to say you could have some hypertrophy that is resulting into an increase in the contractility. So you are increasing the stroke volume and then you're also increasing the ejection fraction. But sometimes if you have a weaker ventricle due to heart failure, you find that the ejection fraction will start reducing because under normal circumstances, the normal range of the ejection fraction should be between 55 to about 70%. Okay, we proceed. So the ejection fraction of the left heart, known as the left ventricular ejection fraction, is calculated by dividing the volume of blood pumped from the left ventricle per beat, which is the stroke volume, by the volume of blood collected in the left ventricle at the end of diastolic filling. So in simple terms, ejection fraction is the stroke volume divided by the end diastolic volume times 100%. Then it will give you the ejection fraction. So the left ventricular ejection fraction is an indicator of the effectiveness of pumping into the systemic circulation because the left side of the heart, you are pumping into the systemic circulation via the aorta. So once you're looking at the left ventricular ejection fraction, that will give you an idea on how the left ventricle is operating because the left ventricle is the one that is pumping into the systemic circulation. Then the right ventricle is pumping into the pulmonary circulation. So if you want to look at the pulmonary circulation, you need to look at the right ejection fraction. So the ejection fraction of the right heart or the right ventricular ejection fraction is a measure of the efficiency of pumping into the pulmonary circulation, like I've already said. So this will give you an idea on how the heart is performing and which part of the heart, whether it's the left part or the right side. So you'll be able to tell from the ejection fraction. So it doesn't mean that you're going to have the same ejection fraction. The right and the left ejection fraction sometimes can differ. Okay, so in most cases, it will be the same, but sometimes due to certain conditions, you find that there will be a difference in terms of the value of the ejection fraction when you compare the left and the right ventricular ejection fraction. So you need to take note of that. A heart which cannot pump sufficient blood to meet the body requirements, such as in heart failure, will often have a reduced ventricular ejection fraction, which is simple and straightforward. So if you have a heart failure, it means that the myocardium is not contracting very well, then the ejection fraction is going to reduce. Because we said ejection fraction is given by dividing the stroke volume divided by the end-diastolic volume. So the stroke volume, so you can see here the stroke volume, which is the end diastolic volume minus the end systolic volume. We've already looked at this. It will give you the stroke volume, the amount of blood that is pumped out of the heart in every heartbeat. That's the stroke volume. Divide by the end diastolic volume. So you can see the end diastolic volume here is the amount of blood in the ventricles at the end of relaxation or diastole. It's called the end diastolic volume. So you're just looking at the fraction of the end diastolic volume that is pumped out of the heart. Then it will give you the ejection fraction. So you multiply this by 100 to give you a percentage. Under normal circumstances, it's supposed to give you on average 60, sometimes 65%. But the range is between 55 to 70. So anything between 55 and 70 is acceptable. So the volumes and the fraction, for instance, I'll give you an example. If I give you a question, maybe it could be a clinical scenario question, and then I give you these values. The end diastolic volume here is 120 milliliters. The end systolic volume, 50 milliliters. Then the stroke volume, which is also called the ejection volume. So the ejection volume is the same as the stroke volume. It's the difference between the end diastolic volume minus the end systolic volume. So the difference between the two here is 70 milliliters. Then the ejection fraction will be the stroke volume, which is 70 milliliters, divided by the end diastolic volume, which is 120 milliliters, times 100%. So when you divide the two, it will give you about 58%. So on average, the normal ejection fraction should be 60, 65, but 58 is also acceptable because it's within the normal range, which is between 55 and 70. So it's reduced a bit, but it's still acceptable. So if the heart rate is 70, what is the cardiac output? So in this same question, I can ask you a follow-up question to say now, if the heart rate for this patient is 70 beats per minute, what is the cardiac output? So the cardiac output is a product of the heart rate and the stroke volume. So you already have your stroke volume here, 70 milliliters. Your heart rate, I've given you 70 beats per minute. So you just multiply 70 multiplied by 70. It will give you 4,900 milliliters per minute, which is also acceptable. It's within the normal value of cardiac output. Okay, so this table is just summarizing the values of this ejection fraction and also end diastolic volumes. So you have the values of the volumes in a 70 kg man. So you can have the measure here, the typical value or the average, and the normal range, the other side. So the first one, end diastolic volume. On average, a normal person should have 120 milliliters as end diastolic volume. Then the range between 65 and 240 milliliters. End systolic volume 50 is the normal one. Normal range 16 to 143 is acceptable. The stroke volume on average is 70 milliliters. The acceptable range 55 to 100 milliliters. The ejection fraction, I've already told you, on average is 60 or 55, but the acceptable range is 55 to 70%. Then the heart rate, by now you understand an average adult man should have a heart rate of around 75, but the acceptable range is 60 to 100, depending on the firing of the SA node. The cardiac output, okay, on average is about 5 liters or 5.25 liters per minute, but the acceptable range is between 4 to 8 liters. So these normal ranges are subjective to activities that one is doing. If you're doing some exercises, you find that there will be an increase. If you're just resting, then there's nothing, there's less of those sympathetic stimulation. You find that you'll be more on the lower side. So there are other factors that will affect the normal ranges, whether you're exercising or you're resting or whatever it is, the activities that you're taking. Okay, so that they will also have an effect on these values, but just not to say these just normal values. Okay, so now let's discuss the actual factors that are affecting the cardiac output. So we've already established that the cardiac output is the heart rate multiplied by the stroke volume. So any factor that is affecting the heart rate and the factors that are affecting the stroke volumes, these will have an effect on cardiac output. So let's start by discussing factors that will have an effect on the heart rate, and then later on we'll discuss factors that will have an effect on the stroke volume. So starting with factors affecting the heart rate. The first one, of course, is age. So age has got an effect on the heart rate. So you know, to say the newborn, the resting heart rates may be about 120 beats per minute. So the newborn, they have higher heart rates as compared to adults. Then as they grow up, we find that the heart rate will start reducing until it will become within the normal range, which is between 60 and 100, but on average, 75 beats per minute. Okay, the other factor that is affecting the heart rate is exercise. You know, to say if an individual is exercising, then the heart rate is also going to increase. So when you're exercising, the heart rate might increase to about 150 beats per minute during exercise. So the stroke volume can also increase from 70, which is the normal average stroke volume, 70 milliliters, to about 130 or to about 150 when you're exercising. So you know, to say the heart rate is going to increase, and also the stroke volume is also going to increase when you're exercising, because the strength of contraction is going to increase when you're exercising. The heart muscles, for instance, you know, to say the heart muscles, these are muscles. So when you're exercising them, they're going to contract more. So it means that the stroke volume is also going to increase, and that will have an effect on the cardiac output. So since the heart is a muscle, exercising it increases its efficiency. So the difference between maximum and resting cardiac output is known as the cardiac reserve. You need to understand this. So the difference between the maximum and the resting cardiac output. The maximum cardiac output is the cardiac output when somebody is exercising. So when you're doing exercise, you know that the heart rate is going to increase, the stroke volume is also going to increase, the cardiac output is going to increase. When you are just seated, you're watching a movie, you are resting, your cardiac output is going to reduce. So if you get the difference between the maximum and the resting cardiac output, this is referred to as cardiac reserve. So it measures the residual capacity of the heart to pump blood. So how much more blood can you pump when you're exercising as compared to when you are resting? So that's the cardiac reserve. Abnormal heart rates due to tachycardia and bradycardia, these will also have an effect on the heart rate. You're talking of tachycardia, there's an increase in heart rate, bradycardia, there's a decrease on heart rate. So since they will have an effect on heart rate, this will also have an effect on cardiac output, because you are multiplying heart rate with stroke volume. So anything that has got an effect on heart rate will have an effect on cardiac output. So bradycardia may be caused by either inherent factors or causes external to the heart. So you can have factors that one can inherit. So due to genetics, find that you can inherit factors that will have And that can predispose you to tachycardia or bradycardia, in this case, bradycardia. But tachycardia is not normal in resting patients. So if somebody is resting, you don't expect someone to have tachycardia. So once you have tachycardia, when you're resting, just not to say that, that's a pathology developing within the heart, or it's driving the heart crazy. So the tachycardia is not normal in resting patient, but may be detected in pregnant women or individuals experiencing extreme stress. So when there is stress, pregnant women, you find that they can have a tachycardia, which is very common in women. Why? It's because when a woman is pregnant, there is an increase in blood volume. So plasma volume is going to increase. When plasma volume is increasing, the venous return is going to increase, and also the contractility of the heart is also going to increase. Then there are also certain hormones that will have an effect on the heart that will result into an increase in the heart rate in pregnant women. And stress, of course, you have hormones like stress hormones that can also increase the heart rate. So many causes of tachycardia may be benign, but the condition may also be correlated with fever, anemia, hypoxia, hyperthyroidism. In hyperthyroidism, you have an increase in thyroid hormones, the T3, T4, the tetraiodothyronine and triiodothyronine. They're going to increase in hyperthyroidism. Then hypersecretion of catecholamines will have an effect on the heart. Then also some cardiomyopathies that are affecting the heart, some disorders of the valves like stenosis and acute exposure to radiation. All these will have an effect on the heart rate. Okay, then the other factors that are affecting the heart rate are the cardiovascular center in the brain. So within the medulla oblongata, you have centers. You have a nucleus which is called nucleus of tractus solitarius that has got an effect on the heart rate. So the nervous control over heart rate is centralized within the two paired cardiovascular centers of the medulla oblongata. So you have the cardio accelerator regions that stimulate activity via the sympathetic stimulation of the cardio accelerator nerves. So you have these cardio accelerator nerves, these are sympathetic. And you know to say the sympathetic, the postganglionic nerve is going to release norepinephrine, and the norepinephrine can go and stimulate the beta-1 receptors of the SA node and the AV node, increasing the heart rate. So you know to say that these are called cardio accelerator nerves. Why? It's because they're going to increase the heart rate. Then there are also what we call cardio inhibitory centers. The cardio inhibitory centers, they're going to decrease the heart activity via the parasympathetic stimulation as one component of the vagus nerve, the cranial nerve number 9. The cranial nerve number 9 is the vagus nerve, and the vagus nerve is the one that is innervating the heart. So both the SA node, the sinoatrial node, and the AV node, the atrioventricular node, they are both innervated by the cranial nerve number 9. So this cranial nerve number 9, these are parasympathetics. It means that the postganglionic nerve is going to release acetylcholine, and this acetylcholine is going to bind to muscarinic receptors, which are called M2 receptors. And the M2 receptors, they have negative inotropic, dromotropic, and chronotropic effect on the heart. The sympathetics, they have positive inotropic, dromotropic, and chronotropic effect on the heart. So because these factors, they have chronotropic effect on the heart, it means some of them, they can increase the heart rate, and some of them, they can decrease the heart rate. The sympathetics, they're going to increase the heart rate. The parasympathetics, they're going to decrease the heart rate. So during rest, both centers provide slight stimulation to the heart, contributing to autonomic tone. So the autonomic tone is whereby somebody is resting, so you don't have much of the sympathetics, you don't have much of the parasympathetics. So there's a balance between the sympathetic stimulation and the parasympathetic stimulation. That is referred to as autonomic tone. That will give you the normal heart rate, that is around 75 beats per minute. but it will be between 60 and 100 beats per minute. That is a normal heart rate as a result of autonomic tone, the balance between the parasympathetics and the sympathetic stimulation of these cardiovascular centers that are found within the brain stem, in the medulla oblongata, to be specific. Then the other factor that has got an effect on the heart rate, it's the broken heart syndrome. The broken heart syndrome, when there's extreme stress from such life events as the death of a loved one, when you lose your parents, your sister, your brothers, and sometimes an emotional breakup. Maybe you break up with your boyfriend, or maybe your girlfriend just left you for another guy, or maybe your boyfriend just left you for another girl. So when there's a breakup, emotional breakup, there's loss of income or foreclosure of home. For instance, if you used your home as collateral to get a loan and then you failed to pay the loan and then they are repossessing that house, there's foreclosure of the house, that may lead into a condition that is referred to as the broken heart syndrome. So this broken heart syndrome, you find that you are emotional to the extent that this will result into an effect on the heart that is including congestive heart failure. So there is recognized effects on the heart which include congestive heart failure due to profound weakening of the myocardium, not related to lack of oxygen. So there is no ischemia, there is no infarction, but you find that there is weakening of the heart because of the emotions as a result of maybe death of the loved one, or maybe emotional breakup, loss of income, foreclosure of home, that will result into malfunction of the heart. So the heart will be becoming weaker. So you find that even the ventricles, the diameter of the ventricles will be reducing because of depression. So this is more of depression. It's called the broken heart syndrome. That will also result into reduced heart rate. So it will have an effect on cardiac output. And also other factors influencing the heart rate. So using a combination of autorhythmicity and innervation, the cardiovascular center is able to provide relatively precise control over heart rate. However, there are a number of other factors that have an impact on heart rate as well, including epinephrine, thyroid hormones, levels of various ions, including calcium, potassium, sodium, body temperature, hypoxia, and pH balance. All these will have an effect on the heart rate. For instance, thyroid hormones. Thyroid hormones are also called metabolic hormones. You're talking of T3, T4. Tetraiodothyronine, triiodothyronine. So these are metabolic hormones that are going to stimulate an increase in body metabolism. So if the metabolism of the body are increasing, the heart rate is also going to increase. Then certain levels of these calcium, potassium, sodium will also have an effect on the heart. If you have an increase in calcium, you find that that will have a positive inotropic effect on the heart. It's going to increase the contractility of the heart, and also the heart rate will be affected. Body temperature, hypoxia, and pH, all these will have an effect on the heart. So this table is just summarizing the major factors increasing the heart rate and the force of contraction. So these are simply factors that are increasing the heart rate and also the force of contraction. So starting with cardio accelerator nerves, to say they're releasing epinephrine, that is increasing the heart rate, like we've already said. Proprioceptors. Proprioceptors, these are receptors that are associated with the muscles and the joints. So within the joints and the muscles, you have proprioceptors that are responding to the motions or the movements of the body. So for instance, when they are stimulated, they're going to cause increased rates of firing during exercise. So when you're exercising, the proprioceptors, they're also sending information that will cause an increase in the heart rate so that you pump more blood to the muscles which are exercising so that they have sufficient oxygen and nutrients. So you find that these proprioceptors, when you're exercising, they are going to increase the heart rate. Then you have the chemoreceptors that are responding to different chemicals. So decreased levels of oxygen, increased levels of hydrogen ions, carbon dioxide, and lactic acid, it will have an effect on the heart rate. So it's going to result into an increase in the heart rate because you have less oxygen. So the body will take it that you are pumping less blood. So you need to increase the pumping of blood. If you have an increase in the levels of hydrogen, it means you're not transporting this hydrogen for excretion. Carbon dioxide, it means that there's buildup of carbon dioxide, so you need to increase the heart rate so that this carbon dioxide is pushed to the lungs for gaseous exchange. Lactic acid is the same. The baroreceptors, so these are responding to pressure changes. So that's why they are called baroreceptors. So decreased rates of firing, indicating falling blood volume or failing blood volume. So when you have falling blood volume levels are falling down or blood pressure is decreasing, you need to stimulate the baroreceptors that will increase the heart rate. The limbic system, anticipation of physical exercise or strong emotions. So when you're going to the gym, you prepare your mind to say you are going to lift heavy metals. So you find that the heartbeat will start increasing as you are approaching that gym. So it's just an anticipation. You're talking of emotions. The limbic system. Catecholamines, these are hormones or neurotransmitters that can have an effect on the heart. So an increase in epinephrine, it will have an increase on heart rate. Then thyroid hormones, the T3, T4, these are metabolic hormones like I've already explained. Calcium, an increase in calcium will result into an increase in heart rate. Potassium, a decrease in potassium, a decrease in sodium will have an increase on heart rate effect. Then the body temperature, increased body temperature will result into an increase in heart rate. Because the body temperature, it means that the core temperature of the body has increased. So you need to lose some of the heat to the outside via the skin. So you find that the heart rate will increase to increase blood supply to the skin so that you are able to lose heat via conduction to the environment. The nicotine and caffeine. So this nicotine and caffeine, these are stimulants that can increase the heart rate as well. So that's why when you're drinking tea that contain a lot of caffeine, you find that you don't sleep easily. Why? It's because you're increasing the heart rate. They're going to stimulate the heart rate. So the heart rate is going to increase. You're pumping more blood to the brain cells, and then the brain cells are active. Okay, so even caffeine will have an effect again. Okay, so these are the factors that will have decreasing heart rate. So factors decreasing the heart rate and the force of contraction. It's just the opposite factors. So the cardioinhibitory nerves that are releasing acetylcholine, of course, proprioceptors, decreased rates of firing following exercise. So after the exercise, now you find that when you sit down, the proprioceptors are not firing action potential, so the heart rate will start reducing because you are done with exercising. Then the chemoreceptors, increased levels of oxygen, decreased levels of hydrogen, carbon dioxide is just the opposite. So you have a decrease in heart rate. Baroreceptors, it's also the opposite here. Increased rates of firing, indicating higher blood volume and pressure. Then it will cause a decrease in heart rate. The limbic system, anticipation of relaxation. So when you are anticipating relaxation, for instance, after working for long hours at work or maybe at school, and then you go home, you want to relax. So you find that the limbic system will cause the heartbeat to reduce because you are about to relax. So you anticipate the relaxation that results into reduction in the heart rate. Catecholamines. So if you have decrease in production of epinephrine, the heart rate will also reduce. Same applies to the thyroid hormones, the decrease in T3, T4, the heart rate will reduce. Calcium, decrease in calcium, an increase in potassium, an increase in sodium will cause a decrease in heart rate. Then body temperature, decrease in body temperature will result into a decrease in heart rate because you don't want to supply this blood to the skin, so it will be contained within the core organs of the body so that you retain the temperature. So to some extent, it will have an effect on the heart rate as well when it's cold. So you know to say that
when it's very cold in hypothermia, your heart actually can stop beating. So hypothermia can kill an individual. Why? It's because it has got a negative chronotropic effect on the heart that will result into having maybe 0 heartbeats per minute. Then you can die out of that. Factors affecting the stroke volume. So these are the last factors now. So we have looked at factors that are affecting the heart rate. So those factors will have an effect on the cardiac output. So now let's discuss the factors that are affecting the stroke volume. They will also have an effect on the heart rate. So let's start. So these factors that are affecting the stroke volume, will start with preload. Preload. Okay, so preload is another. Before we go to preload, maybe let's just have the general information about factors affecting the stroke volume. So many of the same factors that regulate the heart rate also impact the cardiac function by altering the stroke volume. So the factors that will have an effect on the heart rate, most of them will also have an effect on the stroke volume. So most of these factors we've already discussed. So the other factors that we haven't discussed, they're the ones that we'll discuss here, the major factors. So while a number of variables are involved, stroke volume is ultimately dependent upon the difference between the end diastolic volume and the end systolic volume. Remember, we said the stroke volume is the difference between the end diastolic volume minus the end systolic volume. So it's mainly dependent on these volumes, the end diastolic volume and the end systolic volume. The 3 primary factors to consider are preload, or the stretch on the ventricles prior to contraction. So preload simply means the stretch on the ventricles prior to contraction. So this stretch of the ventricles is brought about by the end diastolic volume, the venous return. So the venous return, the more the venous return, the more the stretching of the ventricles. Then it means that the preload is also going to increase. So we have the preload, or the stretch on the ventricles prior to contraction. Then we have contractility. The contractility, or the force or the strength of contraction itself. So we are talking of the contractility of the myocardium themselves. So the state in which these myocardiums are, whether they are in good state or bad state. So it will give you the contractility, which has got an effect on the stroke volume. Then the other factor is the afterload. The afterload is the force the ventricles must generate to pump blood against the resistance in the vessels. Remember, we said large vessels, they are involved in distribution of blood. Then you have small arteries and small arterioles. So the arterioles and the small arteries, they will resist the blood flow. So because they are providing that resistance, then they are putting more workload on the heart. So the force the ventricles must generate to pump blood against the resistance in the vessels is called the afterload. This afterload will have an effect on the stroke volume. So if the afterload is increasing, the stroke volume will be reducing. The cardiac output will be reducing. If the preload is increasing, the stroke volume is going to increase. The cardiac output is going to increase. If the contractility is increasing, the stroke volume is going to increase. The cardiac output is also going to increase. So the preload and the contractility, they have got a positive effect on the cardiac output. The afterload, if it's increasing in case of hypertension, for instance, it means that the force to which the heart has to pump against has increased. So there is more workload on the heart when you have an increase in the afterload. So let's just discuss these 3 primary factors and then we'll end there. for today. So let's start by looking at the preload. So the preload is another way of expressing the endostolic volume. Therefore, the greater the endostolic volume, the greater the preload. Because the preload, we are saying, is the stretch on the ventricular myocardium. So this stretching of ventricular myocardium is affected by the endostolic volume. If the endostolic volume is increasing, then the stretching is more, and the contractility is also going to increase. The stroke volume is also going to increase. So one of the primary factors to consider is the filling time or the duration of the ventricular diastole during which the filling occurs. Remember, during ventricular diastole, that's when you have ventricular filling. So blood is moving from the atria into the ventricles. So the 80% is passive movement, the 20% is as a result of the atrial systole, the contractility of the atria that will push excessive amount. So the filling time, the amount given for these ventricles to fill with blood will have an effect on the preload. So if the filling time is increasing, the preload is also going to increase because much of the blood is going to return to the heart. If the filling time is reducing due to an increase in heart rate, the preload is also going to reduce because you have less blood returning to the heart. So the endostolic volume is also going to reduce. So the cardiac output overall is also going to reduce. So the more rapidly the heart contracts, the shorter the filling time becomes, and the lower the endostolic volume and the preload are. This effect can be partially overcome by increasing the second variable, which is the contractility, and rising the stroke volume. But over time, the heart is unable to compensate for decreasing filling time, and the preload also decreases. It means that when the filling time is reducing, the heart can compensate by increasing the contractility so that it can maintain the stroke volume. But sometimes if the filling time is reduced so much because the heart rate has increased so much, you'll find that the preload is going to reduce because there is no ample time for the ventricles to fill with blood. So with increasing ventricular filling, both the endostolic volume and the preload increase, and the cardiac muscle itself is stretched to a greater degree. So this is where the Frank-Starling mechanism come in. That will increase the contractility. So you need to pay attention here and listen how it takes place. So at rest, there is a little stretch of the ventricular muscle and the sarcomere remains short. With increased ventricular filling, the ventricular muscle is increasingly stretched and the sarcomere length increases. As the sarcomeres reach their optimal length, they will contract more powerfully because more of the myosin heads can bind to the actin on the thin filament, forming cross bridges and increasing the strength of contraction and also increasing the stroke volume. If this process were to continue and the sarcomeres stretch beyond their optimal length, the force of contraction would decrease. However, due to the physical constraints of the location of the heart, this excessive stretch is not a concern. So we are talking of Frank-Starling mechanism, in which I said is similar to length tension relationship in skeletal muscles. So the more the myocardium are stretched, it means that the more the myosin are exposed to actin, and the more the force of contraction. So it means that the force of contraction is going to increase when the ventricular muscles are stretched more, because now more actin will be interacting with myosin. That will bring about a greater force of contraction. So this is explained by the Frank-Starling mechanism. So the relationship between the ventricular stretch and the contraction. So the relationship between the ventricular stretch and the contraction has been stated in a Frank-Starling mechanism, or simply the Starling law of the heart. So the principle here is that within physiological limits, the force of heart contraction is directly proportional to the initial length of the muscle fiber. So it means when the muscle fibers are stretched, then the force of contraction is going to increase as long as this is within the physiological limits. Because if you overstretch this myocardium, then there will be no overlap between the myosin and actin. So to that extent that they can't contract. Even if you stimulate this muscle, it's not going to contract because there is no interaction between the actin and myosin. So this means that the greater the stretch of the ventricular muscle within the limits, I'm talking about within the physiological limits. So the greater the stretch of the ventricular muscle, the more powerful the contraction is, which is in turn going to increase the stroke volume, of course. So therefore, by increasing the preload, you increase the second variable, which is called contractility. So because when preload is increasing, it means you are overstretching the muscles, then the second variable, which is contractility, is also going to increase. So you can see here the principle. So the Frank-Starling law, it states that within the physiological limits, the heart pumps all the blood that returns to it by way of the veins. So an increased venous return, the cardiac muscle stretches to a greater length, exposing more actin to myosin. Then the ventricular muscle contraction with a greater force. So it's going to contract with a greater force, increasing the cardiac output. So this phenomena is referred to as Frank-Starling mechanism, which is the equivalent of length-tension relationship in skeletal muscles. So you can see within the heart here, you have the length of the sarcomere and the stroke volume. So as you are increasing the length of the sarcomere, the force of contraction is also increasing, then the stroke volume is increasing here. So as long as you are within the physiological limits, when you're increasing the length of the sarcomere, you're exposing more of actin to myosin, and then you have a greater force of contraction that will result into an increase in the stroke volume. But when you go beyond here, you can see what is happening. If you go beyond, you overstretch the sarcomere, the myosin won't be interacting with actin. So if myosin is not interacting with actin, the stroke volume will start reducing because the contractility will start reducing. So this is called length-tension relationship in skeletal muscle cells. Then here it's called the Frank-Starling law. Okay, it's the same information here. You have the left ventricular volume, then you have left ventricular pressure. So pressure against volume. So when the volume is increasing, pressure will start increasing. Why? It's because the force of contraction will increase. So under normal circumstances, we say that the end systolic volume should be around 50 milliliters. Then under normal circumstances, the end diastolic volume should be around 120 milliliters. So if you have an increase, so if you have just the normal end diastolic volume and normal end systolic volume, you have just a normal stroke volume, which is around 70 milliliters. But now if you're increasing the venous return, so if you have an increase in terms of venous return, it means that your end diastolic volume is going to increase. Once you increase the end diastolic volume, you are stretching these muscle fibers. So the myocardium will contract with a greater force. So you can see even the pressure is going to increase as you are increasing the end diastolic volume. Even the stroke volume is going to increase once you increase the end diastolic volume because the venous return has increased. So it's still explaining the Frank-Starling law or mechanism. Okay, we proceed. Let's look at contractility without wasting time now. So contractility is simple. So the contractility refers to the force of contraction of the heart muscle with which controls the stroke volume and is the primary parameter for impacting end systolic volume. So, to say when the contractility is increasing, the end systolic volume is going to reduce. The stroke volume is going to increase when you increase the contractility or the muscle fiber. So the more forceful the contraction is, the greater the stroke volume and the smaller the end systolic volume. Simple and straightforward. Less forceful contractions result in small stroke volumes and large end systolic volume, because now the contractility is reducing, so the end systolic volume is going to be large. So when you have less forceful contraction, it means that the stroke volume is going to be small and you're going to have larger end systolic volume, meaning that much of the blood will remain within the ventricles. It's not going to be pumped because the contractility has reduced. Then factors that increase contractility are described as the positive inotropic factors, which we've already discussed these. So the sympathetics that catecholamines, the T3, T4, glucagon, they have a positive inotropic effect on the heart. So they are going to increase the contractility of the heart. For instance, the sympathetics, they know epinephrine is going to bind to the beta-2 receptors of the myocardium. That will result into an increase in calcium within the myocardium that will result into an increase in contractility. So they have a positive inotropic effect on the heart. So the beta-2 receptors, these are G protein coupled receptors. So when this epinephrine goes and binds to the beta-2 receptors of the myocardium, it will bring about positive inotropic effect. Why? They are G protein coupled receptors, of which we say the G protein receptors, they are composed of 3 protein subunits, the alpha, beta, and gamma protein subunits. So when they go and bind, there's activation of the G protein that will cause dissociation of the alpha protein subunit. And this alpha can go and activate an enzyme which is called adenylyl cyclase enzyme that will convert ATP into cyclic AMP. And the cyclic AMP can activate protein kinase A. And once protein kinase A has been activated, it will cause phosphorylation of calcium channels. So once those calcium channels are phosphorylated, they're going to open and allow influx of calcium. That will increase the contractility of the myocardium. So that's why they're called positive inotropic effects. These are sympathetics and also catecholamines like norepinephrine and epinephrine. T3, T4, glucagon, T3, T4, these are metabolic hormones. They're also going to increase the metabolism of the muscle cells and also the contractility of the muscle cells. So positive inotropic factors. So ino means fiber, tropic means turning forward. So there are several synthetic drugs like dopamine, isoproterenol, the